just gone 6, Jane. If you want to crack on, we've got 23 participants, 24, 25. The numbers are going up now, so I'm sure people will join. Will join within the next couple of minutes.
Exactly. So thank you very much, and thanks again to PoTS UK for inviting me to deliver this webinar. And I'm delighted to be able to return. As many of you might know, I'm the physiotherapy advisor to the charity, and I've got a very big interest in PoTS and helping people to manage the condition. So a very warm welcome to all of you. I've got my virtual background on. Behind me you can see the building of University College London, which is my main place of work, where I do my sort of research and education work, but I also work round the corner, do some clinics in the NHS at UCLH and also at the London Hypermobility Unit, where I see and specialise in people with hypermobility spectrum disorders and Ehlers-Danlos loss syndrome, and also lots of people with PoTS or orthostatic intolerance. So I'm going to share my slides now. We are recording the session, and we're aware, I think there were over 80 people who showed an interest in this particular webinar, which is fantastic. So wonderful to be able to reaching that number of people, and people may access this recording later on YouTube. Right, I'm going to share my screen now, and you should be able to see that front slide. And what we're going to be talking about, and I think there's been lots of requests for, is the role of exercise in managing PoTS. And many of you, either patients or health professionals, will be aware of the important role that exercise plays. However, it can be quite a challenge implementing exercise. So this evening I'm going to talk about a bit of background to PoTS, of course, then go into some of the research that we've got and share some of my experiences. So we'll be integrating, as I said, some of the key PoTS related research. Although there's not been a lot, there is a little bit. I'll be sharing some of my anecdotal experiences from working with patients. I've got a couple of case studies to illustrate and hopefully inspire you as well to feel that it is possible if you're a patient, if you're a parent, if you're a carer, if you're a friend, or if you're a therapist or medical professional. And then there'll be some time for questions. So last time when we did the webinar, there wasn't much time for questions, so I'm going to allow hopefully around about half an hour, up to half an hour for questions. So people who present with PoTS present with a range of histories, a range of different signs and symptoms, and you may recognize some of these history, signs and symptoms on this particular slide. There's a lot going on for a lot of people. For most people, the common things, of course, are difficulty perhaps standing upright, perhaps feeling dizzy with a tachycardia, but there may also be pain, lots of tiredness, headache, swollen legs, and if you've also got problems with hypermobile joints, which a lot of people do, there may also be subluxations, dislocations. You may have been a great athlete, you may have been a great dancer, you may not be of any of those things, but you also might have gut problems. So there's often, as I said, a lot going on, and it can really impact on mood and well-being. And the onset of those symptoms might have been something that sort of commenced early on in life. People sometimes commence life with some signs of dysautonomia, which may sort of graduate as they go through their life, and the signs and symptoms sort of start to sort of generally increase, and particularly usually around the time of puberty. For others, it may be that they've sort of fallen from a great height, or there's been a sort of certain time, a traumatic event that's happened that has brought on the PoTS, and that might have been through physical, a physical illness. It may have been sometimes through emotional distress. It may have been something to do with becoming very deconditioned, might have been related to injuries. There's all different, might have been hormonal link. There are many causes and onsets. But as I said, it either tends to be a gradual one or one that comes on suddenly. Some of you may have seen this slide before or something similar. This is our new spider tool, which we use in hypermobility. We also use it in relationship to PoTS. And it's really this particular measure is presented in such a way that there are sort of different domains, common presentations, if you like. And if you sort of run around starting at the top there, often people with PoTS presenting with fatigue, which may be physical, there may be psychological or emotional fatigue. It may be biomechanically related. It may be related to sleep problems, fluids, low vitamin D. It might also link directly with the dysautonomia. The cardiac dysautonomia, often then on the PoTS in particular, orthostatic intolerance with tachycardia, syncope, brain fog, pooling in the limbs, headaches are common. Often people will also, alongside this, have some gastrointestinal manifestations if the autonomic nervous system is involved, and that may present with reflux, constipation, diarrhea, and so forth. Around this spider diagram, you can see the sorts of things that these are the most common types of problems that people present with. And we can scale that up because some people may present more with pain, fatigue, dysautonomia, GI, and anxiety, as would be the case here. Or they might map out where they've got all of this going on. So this kind of gives us a kind of pictorial vision of the different problems that people have. And then it's about tackling each of these different problems, of which exercise is what we're going to focus on tonight, plays a role in many of these, in all of these different symptoms. But the rehabilitation principles are based on the fact that actually once you've got a diagnosis of PoTS and you know what it is, and you suddenly, you can recognize the fact that it's not someone having a heart attack, that actually there's an explanation for chest pains, there's an explanation for the racing heart and the dizziness. From there, as a health professional, it's our role then to give you some reassurance, but that should be reassuring for yourselves to know that you know what the cause of it is. Otherwise, it's terribly frightening and anxious making. Pacing plays a very important role here, and it's particularly important because with fatigue and pain management, if you overdo the activity, then you can go into these stress loads, which you can see pictured here. And that's very important to keep that under control. So we talk a lot about pacing and managing the available energy so that we don't get spikes in pain, we don't get spikes in fatigue. The other thing just to highlight here is really important to kind of agree and set some realistic goals, or try and find what your goals are and your motivators. At times people do need anxiety management, and that might be with cognitive behavior therapy, relaxation, mindfulness, hypnosis, breathing exercises. We talked about that quite a lot in the last webinar, particularly for those with dysfunctional breathing, learning to breathe, to switch on the parasympathetic nervous system and try and settle down that sympathetic drive. But sleep plays an important role, and many people are out of their sleep routines, and helping people to get back into a sleep routine becomes very, very important. About the timing of going to bed, the timing of food, not exercising too late, avoiding too much screen time. And there are apps which can help people with sleep. And I just put one there, which I know of, which has been research-based and developed by Oxford University, the Sleepio app, which is very helpful if people are having problems with sleep. Other thing that's important in the management is often to monitor medications. So you may be on medications, and the role of physio and also of the other health professionals is to sort of monitor and make sure that people are taking their medications and that they're actually hopefully working, and also work with you on the non-pharmacological treatments, of which the use of compression garments to aid venous return can be helpful. You'll probably know about that. having increased fluids and salts to maintain the blood volume. Dietary advice can also be very helpful, because if you eat a big meal, then it can often lead to increased blood flow into the gut, and sometimes an increase in insulin production, particularly if you're having a lot of sugars or carbohydrates. So we tend to say a low carbohydrate diet, and sometimes the FODMAPs diet can be helpful if you've got a very sort of irritable gut. And then it's about designing and implementing exercise and reconditioning programs. And there is evidence suggests that orthostatic intolerance in POTS is related to deconditioning. You know, there's been sort of a debate about whether deconditioning is a cause of POTS or whether it's an outcome or effect of POTS. But regardless of this relationship, because it's not always very clear, deconditioning, if you are deconditioned, it negatively influences cardiovascular function. So if you've been unwell with your POTS, or they've got family members or patients who have been ill with POTS and haven't been able to be physically active, it will influence cardiovascular function. And it is important to get that cardiovascular function back again, and exercise, so that that is part of the recovery phase. And the premise with exercise is there are long-term benefits of improved physical fitness that can counteract orthostatic intolerance. There's increased blood volume, increased cardiac output, so that's the amount of blood that's being pushed out by the heart with each beat, enhanced vascular compression due to increased muscle mass and tone, so it's basically to get that pumping action, improved endothelial function. So this is at the kind of lining of the blood vessels. And this is to ensure that you get a good transfusion of oxygen and nutrients across the cell membranes. And an improved baroreflex, so your ability to adjust to changes in positions. So very, very important to be physically active. It's just the challenge is, how do you become physically active? But there is some research which underpins this approach. This is one bit of research which is often reported. It was done now 10 years ago in America, and it looked at basically having a case-controlled trial of 19 cases of people with POTS and 16 healthy controls, and they're on a graduated exercise program. And they were able to find that over that 3 months, people actually did respond very well, and actually really they no longer had POTS, 10 out of the 19 cases. Now, this is very interesting. It's about, 50%, improvement rate there within 10 out of 19 cases. I think the issue here is that in this particular study, there were no people who had sort of Ehlers-Danlos syndrome or hypermobility, so they were a group that weren't included here. And it, but it does suggest there is some help in this type of 3-month, quite intensive program of exercise for some. The other bit of research which is of interest is slightly more, a little bit more recent, or one in 2011 and another in 2016. And this is just really to show that, exercise can be preferential over some of the medications which may be being given, because there are often side effects associated with those medications. Having said that, my experience is that some people can't do the exercise unless they're on medications. So, exercise, this research does suggest that exercise can be, as good or better than taking a beta blocker. But you need to just be aware that for some people, you actually do need medications often to help, really to help facilitate the rehabilitation process. The aim of exercise and reconditioning is to improve that cardiovascular fitness and to increase lower limb strength and help the blood function, the blood pumping function. Now, we tend to say that it's a really good idea to start with chair pedals Or if you're in bed and you've been laid up for some time, then actually just lying on your back and just moving your feet around, just starting to get some movement is important. But then you might move to chair pedals, you might go to a reclining bicycle, you might go to something like rowing or swimming. So all these are kind of more laying down type exercises, and then progress to the upright. Now, during exercise, people with PoTS have what we call a low stroke volume. So there's not a lot of, there's a reduced amount of blood coming out of the heart with each beat. So that makes them often feel as though they're feeling lightheaded or dizzy, or they have, shortness of breath and weakness when they're exercising. Therefore, lying down or sitting down, often it doesn't put so much strain, and people don't feel quite so lightheaded. So that's why we tend towards the more recumbent positions to start with. We also need to add to that some kind of resistance or strength training. So that might be with body weight, it might be with some light weights or elastic bands. And the resistance training, just to note here, is more demanding on the circulatory system, and it does lead to changes in blood pressure. So if you are starting to do a bit of strength training, you need to avoid these static exercises where you're kind of using a Valsalva or holding your breath, because that might increase the blood pressure, and it might then be followed by a fall in blood pressure. So we recommend that you don't do those kind of what we call isometrics, that you actually do nice rhythmical exercises as well. Now, how often and how hard should people be exercising? This is one of the key things that we're asking over and over again. And this research written by George et al. In 2016 presented an idea of sort of working on exercise across a 3-month period. And you can see there's a kind of color coding, and you can see in the first month it was all in the kind of dark blues, which is very, very light exercise. In the second month it was slightly harder, fairly light, if you see the grading on the right hand side. And by the third month people were getting to somewhat hard. And you can see the types of exercise people were being recommended to do, 3 to 4 times a week of reclining exercise for 20 to 40 minutes, maybe doing 1 time a week of resistance training. Now, the issue here is that for some people this might work, but for many people, certainly my experience is that that doesn't really work. Because the patients often that I'm seeing, I have to start them on a much, much lower level. So you can see here, 20 to 40 minutes. Some of my patients are starting on as little as 2 minutes. I've had even some start on 30 seconds of exercise twice a day. And then, so much lower intensities. And you can see that, again, for some of our patients who are very deconditioned and very unwell, it can take them up to 12 months. But that's okay, because they're on this graduated program. Now, there is some research, a feasibility trial that has been funded to start to examine how we might go about giving exercise to our patients and to people, because I think there's a lot of variability here. The important message to you is that it's important to start on something. And to start at a level that you can manage, that you can pace. And I'll talk a bit more about that in a moment. So I'm going to talk about this first case, and this might ring some bells for some of you. This is an 18-year-old female, onset of symptoms age 16. It was gradual onset, and she'd suffered quite a long-term amount of fatigue over her life, and made worse after her GCSEs, actually, through that terrible GCSE kind of year. Diagnosed with chronic fatigue syndrome in the past, sought some investigations, was diagnosed then with PoTS, got a diagnosis of joint hypermobility syndrome, now we call perhaps hypermobility spectrum disorder. She had some neck and shoulder pain, some back pain. So it wasn't just about the PoTS symptoms, about these other things as well, alongside some gastrointestinal symptoms, some reflux, bloating, and worse around the menstrual cycle. and she wasn't able to attend college. And actually, when her family got in touch with me, she'd been lying in bed for 3 months, pretty much not able to do much at all, managing with help to get to the loo, but most of her life was spent on her back. Now, if we look at this from a spider perspective, she probably met all of these. The spectrum was there on every case. So lots of things need to be tackled. And in this slide, you can see at the top here, I've said the first thing that I talk about with patients is what is going to be the driver. And for all of you listening today, whether you're patients or whether you're therapists or your family members or friends, the motivation is one of the key things that gets people moving. And I find that's one of the things I really need to work with people, to find what's going to help them to have that resilience, to help them drive because they want to get back to whatever or get onto their life. So finding a driver, very important. For this particular person, she was highly motivated to get back to college. She didn't know how she was going to get there, but she really did want to go on to get to college in some way. So that was a real driver for her. And we can talk about sleep hygiene in terms of treatment. If you go around the spider there, we talk about fluids, salt, medications. I'll talk you through the morning regime in a moment with exercise, managing the gut, the urogenital things. For some people, like this person who's quite affected hormonally, sometimes going on to contraceptive pills. So discussion with GPs can be important here about sort of just balancing out the hormones, possibly getting some help with counselling or some support to help with that particularly anxiety. There was a lot of worry, having been in bed for 3 months, there was a lot of fear around moving again and what might happen. So that can be helpful, getting some kind of psychological input. And then it's about managing the joint symptoms and the pain with exercise, advice, and pain management and pacing. So as I said, it's about tackling all those different bits. Now, to start with, someone who is lying in bed for 3 months is not going to suddenly leap out of bed and be able to start exercising. So although you'll see in different websites information that people should get up and start walking and start doing, the reality is for some, it's just that they need to start moving. So in this instance, it was about doing some bed exercises, starting with breathing techniques, starting to move the feet around, maybe trying some bridging exercise, the second picture down, possibly doing some straight leg raising, so getting the legs moving, and even possibly doing some arm exercises. So in this position, it's about moving, getting the circulation going, getting the muscles activated, and possibly doing some recumbent. You can even do some sort of cycling legs when lying down. And then that might be something that can gradually then be progressed into something standing up gradually. Now, we tend to talk about a morning regime. This is that people, when they wake up, they may need to drink something, they may be taking their medications, doing their breathing exercises. If they're able to get up, they can do the exercises on the right-hand side, which is heel raises to get the blood circulating up the body, possibly some sit-to stands from a high position or some squats, and some biceps curls. This is all about getting the circulation going slowly at it. So either lying down or in the upright position, depending on what somebody can do. These are the places to start. And the morning's important because it sets you up for the day. Many people actually feel better after they've started to get that circulation moving. So that's one of the reasons why we recommend a daily regime of, some simple, easy to do exercises that are within your capability. You don't have to start with 2 sets of 15. You might start with 1 set of 5. This case I was talking about was someone who really had to start at a very low level and build up to 15 repetitions and then add another set. So it might be that you're increasing by, 1 repetition every every 2 or 3 days, with the first goal of trying to get up to this total of 30, which with some rests in between. Alongside that, or moving towards that, and in this case, the family did acquire one of these recumbent bikes. Now, the reason for this is I'll often say to people, I much prefer you spend the money on getting one of these bikes than paying the money to come and see me, because a bike like this doesn't have to be a very expensive one. It is one that can be put together. But what's good about this sort of recumbent bike is you can sort of sit back, and that can be very helpful for people, particularly if they've got back pain or if they're feeling rather nervous, and also if you've got knee pain. The recumbent bike is often better for people who have knee pain. Some of my patients have actually hired these bikes. You can hire them from companies who now hire them out, but for probably between £100 and £200, a bike like this can be bought. You can spend a lot, or you can spend a smaller amount. But this puts less pressure on the heart. It makes it more possible, and it really does focus on the legs. So she started with 30 seconds a day, twice a day, and gradually started to increase by 30 seconds a week, and then increasing by a minute a week. So until someone gets up to, usually we say, 15 to 20 minutes of exercise. And then other things that we can then add to that exercise. Yeah. And then slowly the other way, thinking about. Yeah, so getting the shoulders working, perhaps getting what we call closed chain knee work. And this is particularly for our hypermobile group. Getting, some work on the ball. We might move towards that. You've got people who've got back pain. So a range of different exercises that can then be given depending on obviously what the problems are, but we do need to rehabilitate the whole body. Now, I asked this particular person, because it was a success story over time, I have to say. It was over a 6-month period, and this young woman did get to go to college. And I asked what helped. And what she reported was knowing where to start, because I think that's often the problem for some people. So they read books, go online, and different people say different things. But if you're not sure and you are finding it hard in the upright, then doing some of the bed exercises to begin with, and working towards doing 2 sets of 15 of exercises. And there are some good examples of Pilates type exercises on the PoTS website that you can do. Having a plan helps. So knowing what the plan is, what to do next, and perhaps having someone to help coach can also be incredibly important. So that might be a physiotherapist, it might be a family member, it might be an exercise professional, but having someone to report into, to share the highs and the lows, or working with a group can be very helpful. But for her, it was about having some targets to hit, really realizing there are going to be some up and down days, but recognizing that because we'd set the right baseline, she could see the progression over time. So I'll move on to another case, and this is a 20-year-old man with the onset of symptoms at age 18, so still quite a young man. And as you know, a lot of people do start their symptoms early after a viral infection, diagnosed with chronic fatigue syndrome, had been on a graded walking and physical activity program via one of the NHS trusts who are offering this as part of a trial for chronic fatigue, not so much for PoTS. Managed to get to 15 minutes of walking, then would get a setback, got depressed, so he sought further investigations, got a diagnosis of PoTS because, as I said, being sort of palmed off with the chronic fatigue syndrome wasn't really explaining everything, and hypermobility. He had back pain, leg pain, some gastrointestinal symptoms as well. And if we look at him on the spider, you see something fairly similar, though without the urogenital type of problems. Again, we can deal with lots of these different things, but importantly, again, finding out what his driver was, very, very important. So for this young man, he was a musician. He was keen to get back to music, but he found he sort of recognized that, you know, being in the musical world was a tough call. It was probably something very hard to, you know, the very late nights, a very stressful environment was challenging. For him, he needed to seek another way forward. And I think that was part of the problem when he was in his walking program. He didn't really know where he was walking to. So he actually, I think got it on the next slide, did actually seek some input from psychiatry at this point, because he was so actually very, very depressed. And psychiatrists was very helpful who actually prescribed something called escitalopram, which helped with the depressive side of the symptoms, but also helpful for pain management. So a lot of these kind of medications can often help with pain management, helped a bit with mood, alongside having some psychological support to help with mentorship, to help him to know where he was going. And we talked about what role he would like me to have. It was more, again, in this coaching role alongside the psychological support, talking through the exercises, you know, thinking about what was going to work and what wasn't going to work, because he'd had these ups and downs, and that makes people very nervous about whether they can actually achieve this, and whether they can actually, you know, they lose confidence a little bit. So I think a lot of this was also about a confidence. And these are, you know, as I said, this is someone who had previously been well, but, you know, knocked down by a virus. So again, rather than go back to the walking at this point, we started on the recumbent bike. We got the gym ball working. So some of this is more recumbent type exercise. And you can see, yeah, starting to do this kind of work. It was actually a bit better at this time when I took the videos. We also did some work on looking and making sure, you know, his mechanics were okay. So you can see here, really important, because these ankles and feet, you know, can cause a lot of problems. So teaching people how to move and getting the right sort of devices, perhaps orthotics, to help as well. And then thinking about some weight training. Yep, so eventually getting him into some higher level squatting. And actually, I think for him, it was also about then starting back and getting some work as a teaching assistant, because he recognised that was a direction that he wanted to go in. So he got some part-time work. And he got a girlfriend. I think that was also another thing that was probably helpful, in someone to walk with. So it's really about a very holistic approach here. And then eventually signing up to Birkbeck, which some of you who live in the UK may be aware of, but in London, Birkbeck College is our university which provides education for people in the evening, because he really wasn't someone who could manage daytime education. Actually, this evening education, or for some people, the open universities, can be helpful with online learning. And he went on to do his training in education. And actually, I've been in touch with him recently. He's actually now gone on to actually study psychotherapy. So he's going on to his MA now. So there are still some ups and downs. He does sometimes need to go back onto those medications, particularly around some of his depressive symptoms as well, or to manage the pain. But he knows that the role of exercise is very, very important. And as a whole, I do say to people that once you start to get your PoTS under control, then maintaining that regular exercise, trying to get at least 30 minutes of exercise on 4 or 5 days of the week, supported by some kind of resistance work, is something that helps assist the system. And it doesn't just help. It doesn't just help with the PoTS symptoms. It actually, I'll just go back to one of my earlier slides. It also helps with many of these other symptoms. You know, things like managing, you know, any mental health issues. So we know there's good evidence to show that exercise is helpful for anxiety and depression management. Exercise will help with any of the musculoskeletal symptoms. It does help with even many gastrointestinal problems, particularly if people are constipated. And it can help with fatigue as well, and it certainly helps with the cardiac dysautonomia. It's about getting the dosage right, starting at the right point. So there are just a couple of examples of cases that we've worked with. They are more successful cases, and on the whole, I find that if people are in the right place to start, and if they need medications and they've got access to medications, that is helpful, but not everybody needs the medications. All the patients that I've talked to about how they've been successful have said it takes persistence, resilience, having a light at the end of the tunnel, knowing that actually there is a way forward. And certainly doing nothing is not an option for POTS. Doing something is very, very important. So it's about finding where that starting point is. So I've finished my talking now, and we're going to have at least, we've got some time now for you to be asking questions and commenting on anything that you want to. So I'll stop the sharing, and perhaps I can ask for some help with the questions.
Hi Jane, we have had one email in from a lady called Rachel. She said, when I am feeling well, I am able to do an hour of intense exercise in hockey. When I am unwell with my POTS, I can barely get off the floor. Will an exercise program benefit me? Thank you.
Yeah, so I mean, one of the things is probably just to determine in answer to that question is, do we know what the cause of those bad days are? Is it that there's been a boom of activity? And it may be with the hockey, or it may be other things that are triggering that. So it's really sort of finding out, and by keeping a diary, you can often determine what's sort of causing that bust, if you like, the boom bust. So exercise is always going to be important. So it's always going to be an important part of well-being, whether it's, the fact that, this person can manage to play quite intense sport means there is a level of fitness already there. But my question would be, is the exercise intensity one of the things that's causing the crash? And if it is, it may be that aspect needs to be monitored. But exercise will always play a role, because we always want to make sure that the stroke volume, that the cardiac output, that the blood volumes are at a good level. So I hope that answers that question. I can see some other questions.
Yeah, in the Q&A box at the bottom, we just have 5 to go through.
Okay. So the first question I can see there is, did this patient have PEM after any of these exercises? PEM, I'm not quite sure what the PEM is. Post-exercise malaise, maybe? I don't know if Nicola can type any more things in there to help me. I need a bit more detail on that.
And I think maybe Nicola is referring to the post-exertional malice.
Okay, so, and presumably this is in relationship to either the first or the second case. In either case, it's often the case that people do feel post-exercise malaise. What I think is very important, and what I work with my patients, is to try and find the baseline that doesn't allow them, where the malaise or any of the symptoms aren't aggravated to a point where it lays them out for 2 days afterwards. So I'm prepared, and that I help them to prepare for the fact they might feel a little bit of exertional malaise, and we can talk a little bit about graded exposure, but generally, if people are suffering with post-exercise malaise, then it's about it being too intense or too much. So it might be that we've either got to cut down the intensity, or we've got to cut back the time and find where the baseline is. And then it's perhaps if that is a big feature, it's then about grading that exposure. I hope that answers your question, Nicola. Okay, so the next one from Natalie. Many patients with ME have post-exertional malaise. That's another one. Would your advice be different for these? So I think similar, Natalie, to what I've just talked about. The malaise is a horrible feeling, and often people do feel this awful feeling of sickness as well. And so I think the answer there is, like a lot of things, it's probably doing a little bit at a time. And as I said, it can be very helpful to think about this as some kind of graded exposure to things. So a little bit of exposure, but not too much, particularly if malaise is a problem. Natalie, again, do you use heart rate monitoring for some of your exercise patients? Right. I've been through different phases with the use of monitoring. Some people use the monitoring. Sometimes we work with monitors and sometimes not. What I don't want is for people to become obsessed with their heart rate. That's why I put that slide up with the Borg scale, which is more about how the feeling is. How, because on different days you might feel differently about this. There is actually quite a good relationship or quite a strong relationship between how it feels and what your heart rate's doing. So I think the issue here is, as I said, often that people just really get sort of stuck on their heart rate, and then either worry they're going too high or too low. However, when I'm showing people in our gym how to manage exercise, I'll take them to an exercise level. If they've got heart rate monitoring on their bikes or anything like that, they can look at the heart rate. I will say that generally there's probably a 5 to 10% error rate, so don't always trust it, but do trust how you're feeling on this. So, yes, heart rate's important, but we just need to be careful, particularly if people really worry if their heart rates are going very high, or if there are beta blockers where you can't always gauge the actual heart rate because it's being held by the beta blocker. So it depends is the answer. Anonymous attendee, should you push yourself to try and exercise even on days when you're symptomatic and feeling unwell, or is it best only to exercise when you feel well enough? That's a good question. Thank you very much for that question. Well, they're all good questions, but that's one that comes up quite a lot. So how I tend to tackle this is with saying to people that there's 7 days in the week. We do need to exercise, to be doing something most days. But in terms of the cardiovascular work, I'll tend to be saying 4 to 5 times a week, which leaves a couple of 2 or 3 days for when people are feeling perhaps really rotten, really don't feel up to it, or they can sort of pace their way through the week. And the same with their resistance training. We're only usually doing that a couple of times a week. What I do say is with the morning regime, unless people are, got a temperature and really unwell in that respect, or they're, feeling so nauseous as they're going to throw up, or their headache is banging so hard that they can't, then I'll say, modify that. But trying at least be moving the limbs around so that the circulation is going. But if you work on the basis of 4 to 5 times a week, it does leave a couple of 2 or 3 days where, you might just be coping, but you do need to be doing something most days. When's it safe to restart after a big 2-month and counting setback? Okay, well, I think we talk often about managing setbacks, and I think it's important to sort of work out how to manage a setback, because there will be ups and downs. So the best thing to do is you might have, prior to a setback, and worked yourself up to quite a high level. And then you've had a setback and you feel like you've sort of fallen down again. So I think it's then about finding where the baseline is. And so always, you can err on the side of caution, because what you want to do is be building up your confidence, building up your cardiovascular fitness again. So it may be that you're just going to start with something very simple. And unless there's some reason why you can't do anything, you should be doing something, Jill. That, as I said, it might start with just some recumbent lying down exercises in bed, moving the feet around, maybe doing some straight leg raising or some bridging, to just start moving. And if you feel you can do a bit of cardiovascular, maybe get on the exercise bike or on the exercise pedals, and just start very low level and tick that one off and think, right, I managed that today, monitor, and then come back to it. Right, so I'm getting more of these questions coming in. Thanks very much for all the questions. Does exercise help with chronic dizziness when standing up? So Georgia, that's from Georgia Marshall. So Georgia, that really depends on what's causing the dizziness. So dizziness can be caused by lots of different things. If the dizziness is coming on also with a tachycardia, so with an increased heart rate, then it's possibly likely that it's going to be related to the circulation, and exercise can help that as long as you are well hydrated. So it definitely can help with dizziness, but if the dizziness is being caused by, sometimes you get dizziness associated with your vestibular system, sometimes it's dizziness related to neck problems and other problems, in which case it's a different type of exercises that will need to be done. So there's vestibular exercises, which are about sort of using the eyes, turning the head. There's a set approach to that. But if the dizziness is related directly to the PoTS and improving the circulation, improving that kind of blood flow, that cardiac output, that stroke volume, then it most definitely can help. Coming down the list, Sarah Kavanagh, will exercise help my dizziness? I think I've just responded to that one, Sarah. I've found I have to do it for at least 5 to 10 minutes to make a difference. And that can be the case. So actually you need to sort of keep going with it because the circulation is starting to move. And it might help. Is there anything I can do with the exercise to help? So what I'd say is don't eat food. If I wouldn't have a big carbohydrate meal, because that can often make your insulin will be a vasodilator, can often make you feel a bit more dizzy. So a little bit of food, certainly drinking, certainly having isotonic drinks with salt or anything like that, wearing flight socks or wearing compression garments may be helpful. So those things can be helpful in exercising and may help reduce the dizziness, and also doing something that's a bit more recumbent, so more of a sitting down exercise or rowing or those sorts of things might be a good starting place. Other questions coming in. So I think I'm slightly sometimes losing the order here, but someone, an anonymous attendee has asked, have ME, PoTS and EDS3 for 3 years after a viral infection. I've just started horse riding. What are the advantages and disadvantages for PoTS on this? I'm enjoying it, but struggle with the post-exercise malay. Okay, so well, firstly, I think horse riding can be very helpful for EDS. I quite like it for EDS as long as it's not galloping around, jumping over big stiles and things like that. One of the reasons why it can be helpful is because it's more closed chain exercise. It's quite good for posture. In terms of how it might help PoTS, well, I think it is a more seated activity, so that's not putting so much stress as an upright activity. There is some element of certainly some muscle work. It's not so cardiovascular. I definitely think, so you will be getting muscle toning from that, and certainly a huge amount of enjoyment and to help the mental health. So that's also very, very important. But the post-exercise malay the day after is obviously a bit of an issue. So you're weighing up, the quality of the experience, the feeling with what you feel the next day. So again, this might come down to how much you're doing. And depending on how long you're out there horse riding, it may be that you just got to cut it down a bit or have a break. It's about finding those baseline levels. Other questions, Jill Gray, if on a beta blocker or ivabradine, do you need to be careful about exertion? Okay, so I mean, obviously the beta blockers and ivabradine are managing the heart rate, and that's what I was saying in terms of, you know, using heart rate monitors. They don't really, you know, apply so much here because the heart rate is being sort of managed, if you like. That's why I use that Borg scale. So later on, you will get access to these slides, and using the Borg scale is quite helpful. And you want to be thinking at what grading am I want to work. And I would say for many of you who are just starting back into exercise, on the whole, you want to be working at kind of a light to moderately light level. And that's what you should be feeling. You will be getting an exercise effect from that, but you won't be overstraining either. So hopefully that is answering Jill's question there. Nicola's mentioned that she felt those people perhaps were wrongly diagnosed. Yeah, this is very likely, Nicola. They were wrongly diagnosed, or they may have had a coexisting condition. I think the key thing is getting that PoTS diagnosis is very, very important for people to get. But, you know, certainly chronic fatigue plays a role there. Managing the fatigue aspects of PoTS also is important. So, as I said, we do a lot of that with pacing, but also with exercise can be helpful. And we know even in managing chronic fatigue syndromes, graded exercise is shown to be helpful there. But certainly with PoTS, we need it. It's a common misdiagnosis, or certainly a common co-diagnosis. Thanks, Natalie. You've just popped in there the postexertional malaise. I can see that. So Jennifer Roberts, any suggestions, please, for my condition? Slight EDS and PoTS, cardiac rehabilitation is suggested. The autonomic physio department in London, I'm unable to do it all. I'm not quite sure what the question here, but it sounds like cardiac rehab was recommended. Now, the problem might be that if you're going along to a cardiac rehab program, that's going to have been set up for people who've had heart attacks or they've had heart surgery. And although PoTS does kind of link in with the heart in that there's issues with the tachycardia or circulatory issues, and there are elements of cardiac rehabilitation that need to be undertaken. The issue with PoTS is more that the orthostatic element, the standing up elements. So if you are going along to cardiac rehab, I think you'd have to be, the rehab team would need to be mindful that actually just standing up might be the issue, or changing from lying down to sitting or sitting to standing up. So it might be that with some discussion and perhaps by pointing those therapists or the rehab team to some of the PoTS information, it might be that you could do more of the work in a sitting position to start with rather than the standing work. Right, a few more questions coming in. Pamela Indu, has the program been effective with those with chronic migraine? Right. This is a really difficult one, Pamela. Managing migraine, and I think for a lot of you who do have headache problems, so sometimes the headaches can be a result of the circulatory problems, and of course, you know, improving circulation to some extent may be helpful. Sometimes headaches are caused by neck problems, but migraine, of course, there can be many, many causes, but we do see migraine associated with PoTS. And this is where often doing too much intense exercise can trigger, you know, certainly might make the migraine feel worse. I haven't seen a situation where exercise has actually helped someone with a migraine as they've had it improve their migraine pain. They normally have to just lie quietly, you know, depending on whether they've got auras or other issues, and get over their migraine. But what I say to them is that ultimately, when the migraine's not present, exercising at a low level to start with may help you to manage the migraines. But the migraines will also need to be addressed, most likely by someone who deals specifically with migraines itself. So with headache, migraine, trying to find the cause is very, very important. But many of you will know when you've had a headache or you've had a migraine, you try and exercise, it can sometimes just make you feel quite a lot worse and more sick. So migraine would be one of those days when I'd say, right, those days you would be probably doing very little. So I have EDS and psoriatic spondyloarthritis, which of course seriously affects my joints and connective tissues, causing widespread intense pain. Due to this pain, I struggle even to walk. I try to do stretching and resistance, which brings on post-exercise malay, but anything else brings the big PoTS flare up. So thank you, Hannah, for that. Really challenging for you to have this combined condition. Now, what I would say again is that generally with post-exercise malay, it tends to be, and all the research that we've looked at with people with fibromyalgia and other conditions like this, where we get this post-exercise malay, it's usually to do with the intensity of the exercise or the time spent. So it is about trying to find the baseline and also gradually increasing the exposure. So it may be to start with, the sorts of exercises I was talking about today, just starting very gently. It might just be with 4 or 5 repetitions, and it might be just with some of those lying down exercises to begin with. But it might be on a recumbent bike at a very low intensity, just doing 1 or 2 minutes to start with and gradually building up. But if you push hard, it's likely to flare up your it will flare up your malaise, and it might also stir up the joint symptoms. So it's probably at this point low intensity exercise on the whole. It's very difficult without examining you to be able to say exactly, but it's usually about tackling the various bits there that I talked about. Rachel Lacey, so thank you for answering my question. I'm Rachel that plays hockey. Oh, thank you. I work as a full-time primary school teacher. I'm a mum of 6 and I'm very active. My PoTS seems to flare every few months and I feel very unwell, dizzy and faint at the point I can't stand up. It passes and after a week or two I'm back to normal busy life. So I'm just wondering, I think keeping a diary is very, very helpful, Rachel. You need to think about whether there is, what are the things that might be triggering? Is it hormonal? Is there that you sound like you've got quite a busy life as well? Is it all just sort of brimming up and that's something that's triggering this? I think everyone's got this, some kind of equilibrium here, but if you are a bit on the dysautonomic, if you are dysautonomic, it's about finding what those triggers are. And as I said, I think generally though, trying to stay active is important, but just watch how active. And it may be that you need to sort of manage that a little bit more. Georgia Bennett, I'm worried about my levels of anxiety and confidence when it comes to my morning regime. Would you suggest I need to explore CBT? If so, how would I address getting this help? So thank you, Georgia. And I think you're like a lot of people. I think the worry, we'll often have people who really struggle with, how's this going to feel? What's it going to do to me? How will I cope? Now, there obviously are, many, there are lots of ways to get access to psychological services. Unfortunately, you may not always find it through, if you're in the UK, in the NHS, because they may not have those things available. But you can, of course, ask for help. And many trusts do have, CBT offerings for people who are suffering with anxiety and confidence issues. So, do first ask at your with your GP and in your local trust for some support with that. But if not, then there are we do have a psychologist who is part of the the psychology team as part of the PoTS UK, so they'll be able to advise there. We do also. If you wanted to email me afterwards, I can give you some suggestions of where else you might find some psychological support. And and often it is just about just getting the confidence to start. But, you know, you don't have to wait for the psychology either. You can also just think about doing one small bit, something tomorrow morning. Even if it's just starting with moving your ankles up and down and starting to do some bed exercises and, you know, seeing if you can manage that. You know, it is about starting somewhere. So, but I'm very happy to give some information on that to you. There's lots of Nicola Claw Baker. There's lots of research by the Work Well Foundation with people with in the years showing that there's significant abnormalities exercise physio. Okay. So thanks for this, Nicola. You know, this is a very complex area, and there are, you know, things are on the spectrum, and there are some times when you can have the mitochondria, there can be mitochondria disease, there can be all sorts of issues around the physiology. Mitochondrial disease itself has to be managed very, very carefully. So difficult to know, because you might be wondering, have I got mitochondrial disease? I think it does become apparent because in starting any of the exercise programs, the elements of fatigue just become so clear, and that you can't, you know, this post-exercise malaise becomes something you just can't manage. But I'm not quite sure what else to say there, other than yes, to recognise some people have mitochondrial disease. I don't think it's not a common disease, so I don't think all of you should immediately think I've got mitochondrial disease. But what I will say to you, if you haven't been exercising much for a while, you will have reduced mitochondria, which are the oxygen producing cells inside the muscle. You will have less of those. So you do grow mitochondria as you get fitter. So it's just to bear in mind. Mitochondrial disease itself is actually a defect in the mitochondria. But for all of us who perhaps if you haven't done a lot of exercise at all, then you'll have reduced mitochondria, and that will affect your ability to metabolize lactic acid and all sorts of other things. So, so thanks for that comment. Krista O'Brien, when I stand, I sometimes have a lot of trouble moving properly. My gait becomes odd and my movement is not fluid. I often need a walk on these days. Do you have exercise or movement session to get back on track? Again, difficult here, Krista, to know exactly what's going on for you and why this is happening. It sounds probably, you know, as I said, very difficult to know without sort of assessing you exactly what's going on there. But generally, yeah, so I know I can answer that, well, you know, without examining you to what's causing this sort of jagged movement, if it's pain or whether it's stiffness or whether there's something else going on with that. And obviously, you know, you probably do need to see a therapist. I think I would suggest that might be something that would be of use to you. But if you are struggling, you know, there's certainly exercises, those sort of core exercises that I've just shown you are things that will, you know, they're basic, simple exercises that would be helpful for everybody, but they won't necessarily improve the fluidity of your movement. We need to understand what is actually causing that. And Krista, I think it's the same one. My energy levels fluctuate greatly, and I'm no longer a reliable employee or person in general. I'm off work because of this. Oh, I know, and you know, Krista, I think a lot of people feel the same way as you. That with this huge fluctuation, it does make you feel as though you feel as though your symptoms are controlling you, and that you can't be the reliable person that you want to be, or to your employees, or to family, and to yourself. I think this is a real challenge for many, many people. And we do talk a lot about, which is why I talk about the diaries or looking at the spider, seeing if there are ways to tackle each of those areas. You know, trying to get that focus again is very, very important. Exercise, though, does play an important, even at a very low level, it plays a very, very important role in equilibrium. So doing something is helpful, but it might also be that you need some additional help and possibly some psychological input to help you with this, because I think those feelings that you're having, can make you feel quite down as well and lose confidence. And so getting some help and trying to sort of see it, I often say to people, it's about turning this around so that you don't feel as though your condition is defining you, and that the symptoms are controlling you, that actually as you get to understand through diaries and through understanding what makes you feel better and what makes you feel worse, you start to be able to manage those situations. Right, Georgia Bennett, yeah, right. I think, Georgia, I think you probably need to email me. So my email is at the end of the slides. You could email me and I can get back to you on that. Nicola Asamoah, I normally do yoga Pilates 3 times a week and use the exercise bike once. Yeah, okay. So Nicola, it's difficult to know exactly what your symptoms are or where you're at, but great, you're doing a Pilates. But I think what you need, it sounds like what you need is a bit more of the cardiovascular side of things. So that's where, as we say, we tend to recommend doing 4 to 5 times a week of some form of cardio, which might be bike, it might be rowing machine, it might be walking. So let's try and step that up, but don't go too fast at it. Start at a low level and build up. How can sorry, Natalie, how can PoTS be diagnosed if a person can't make it to see a cardiologist as they are house and bed bound? I think you won't be able to get the diagnosis. There are many consultants at the moment, though, doing certainly some online Zoom consultations. That's been one of the better sides of COVID, in that it has opened up that world. You wouldn't be able to get the diagnosis without having, obviously ultimately attending. So I don't think you can necessarily get it without ultimately getting out and about, but I think you could start to explore now the potential for certainly some of the consultants doing initial Zoom consultations and being able to start giving you some of that advice. So that is part of, what is being offered in a lot of services now. I think that's all the questions. Well, a lot. Thank you very much for all those questions. And I'm hoping that those people who feel as though we've been able to answer those. Okay.
Yep. That's perfect. Yeah, that was all of them. Thank you everyone for attending. This was recorded, so if you missed any of it, if you joined late or you just want to rewatch or share it with friends, family, it will be up on our YouTube at some point over the weekend, and keep an eye on our Facebook page. It will be posted there as well. So thank you very much.
Great. Well, as I said, it was lovely that you could attend, and I do appreciate that. It's hard to get information. Each of you are individuals. Each of you, or your families, or if you're a health professional, everybody will be different. But exercise plays some role. I don't think there's many conditions in the world where exercise isn't helpful. I think migraine is a tricky one, and you need to manage that. But ultimately, it may be that exercise is part of helping preventing the onset of migraine. And many of you mentioned a post-exercise malaise, which is a challenge, and which is why think about low intensity. So think about on the Borg scale, very light to moderate exercise, not pushing the higher levels. Okay, so I'm going to wish you all well. I hope to meet you all again at some point in the future. Thank you very much again to PoTS UK for being here and supporting us, to Joe for arranging all of this, and all the best with your lives. Do email me if you've got a question. I'm happy to answer some emails. So my email is Jane, Jane. I can put it in the chat, actually. I'll just put it there if you want to email me. Okay. I won't be able to answer a massive, great load of questions, but if you've got, you want a recommendation or something, then that is my email. Okay. So all the best and good night.